Welcome to our speakers. We have an amazing, as always, talk today with excellent, highly expert speakers. And I can't wait to introduce each of you. We have three speakers today where we're blessed with so much expertise today. So here we go. I'm Barbara Stewart, by the way. Hi, we never met in person or virtually. Nice to meet you.
You too.
All right. So first I'll start with Dr. Shannon Lundy, is a pediatric neuropsychologist and associate clinical professor, as well as the director of psychology services in the Division of Developmental Medicine, Department of Pediatrics. She's also the neurodevelopmental program director for the Clinical Research Services, Clinical and Translational Science Institute Neurodevelopmental Assessment Program, which provides consultation and assessment services. I lost my track here. And assessment services for pediatric clinical research studies. Dr. Lundy received her PhD in clinical and school psychology program at the University of Arizona. She then completed a predoctoral internship in clinical psychology at the University of Arizona College of Medicine, followed by a fellowship in pediatric neuropsychology at Boston Children's Hospital and the Cambridge Health Alliance, affiliates of Harvard Medical School. Her expertise includes pediatric oncology, central nervous system injuries, pediatric multiple sclerosis, and various neurodevelopmental disorders, such as neurofibromatosis. Dr. Stephany Cox is a pediatric neuropsychologist and assistant clinical professor in developmental medicine and pediatric cardiology. She also serves as the co-director of the Healthy Hearts and Minds program, a neurodevelopmental follow-up program for children with congenital heart disease within the UCSF Pediatric Heart Center. Dr. Cox received her PhD in clinical and school psychology from the University of Virginia, then completed a predoctoral internship in pediatric psychology at Children's Hospital, Children's Hospital Orange County, followed by a postdoctoral fellowship in pediatric neuropsychology at Children's National in Washington, D.C. Her expertise includes CHD, genetic disorders, extreme prematurity, neonatal brain injuries, and pediatric cancer. She also has extensive clinical and research experience with neurodevelopmental disorders, especially autism spectrum disorder. And Dr. Gina Pfeifle. Did I pronounce your name correctly?
Yes, that's great. Good job.
Thank you. Okay. Dr. Pfeifle is a pediatric neuropsychologist and assistant clinical professor in developmental medicine. She also serves as the training director for the UCSF Division of Developmental Medicine's Pediatric Neuropsychology Externship. Dr. Pfeifle earned a doctorate in educational and school psychology from the University of Texas at Austin. She completed a predoctoral internship in pediatric psychology and neuropsychology at Texas Children's Hospital and a postdoctoral fellowship in pediatric neuropsychology at Children's Healthcare of Atlanta. Her clinical work has a particular expertise in caring for patients with spina bifida and is a member of the multidisciplinary team for the spina bifida program here at UCSF. Her other areas of interest and expertise include acquired and traumatic brain injuries, genetic disorders, including neurofibromatosis type 1, pediatric cancers, and neurodevelopmental disorders, including autism spectrum disorder and attention deficit hyperactivity disorder. Whew, can't wait. Can't wait. Okay, thank you for all of this and for all the work that you've done, and let's roll.
All right. Hi, everyone. So I'll be starting off today. Thank you all so much for having us here. We're excited to talk to you all about pediatric neuropsychology here at UCSF, but also as an overall field within the medical setting. Next slide, please. I'll start off with an introduction to pediatric neuropsychological evaluation, including the utility of this type of assessment, the included components, and what the difference is between pediatric and adult neuropsychology. Then Dr. Lundy will go into how we use a developmental orientation within our clinical practice. This includes the intersection between development and medical vulnerabilities, as well as the impact of medical conditions and treatment on the developing brain. Finally, Dr. Cox will review medical disorders commonly seen in our specialty clinics and their associated neurocognitive profiles and frequently encountered neurodevelopmental and psychological diagnoses. Next slide, please. Let's start by giving a background about pediatric neuropsychology. Next slide, please. Pediatric neuropsychology is a specialty within clinical psychology that is most concerned with the way the brain impacts behavior. Accepted training standards for specialization in pediatric neuropsychology include specific graduate coursework and clinical training in neuroanatomy, medical disorders, and clinical psychology, including a predoctoral internship and 2-year postdoctoral fellowship in pediatric neuropsychology. Next slide, please. The utility of a pediatric neuropsychology evaluation within the medical setting includes helping the medical team to clarify developmental and/or psychological diagnoses in the context of the child's underlying medical disorder, helping family members and medical teams develop a better understanding of who the child is in the context of their specific situation, meaning their particular medical disorder, family context, and cultural background, and importantly, to help guide interventions that will help support the child. These can be cognitive, academic, or psychosocial in nature. Next slide, please. The goal of a neuropsychological evaluation is to tell a story of who this child is, to help foster an understanding of their needs. And how do we do this? First, we obtain a comprehensive review of patient history, including an integrated presentation of family, medical, developmental, social, emotional, and educational history. Next, we evaluate the overall cognitive profile of a child, looking at a variety of domains and highlighting their specific patterns of strengths and weaknesses. Clinical analysis is then conducted based on collected data and history in the context of relevant medical disorder, when it happened in development, what was affected, what was the treatment course, and how does that play a role in who this child is now. Finally, we make appropriate recommendations and interventions tailored for the patient. This includes services and supports across all settings. Next slide, please. Goals for pediatric and adult evaluations can be similar in some ways and quite different in others. So both pediatric and adult neuropsychology is used to help connect the way medical conditions are impacting overall cognitive abilities and daily functioning. That is, one's success and independence in their daily life. The difference is in how that information is then used. For children, there's a greater focus on remediation, optimizing development, and preparing for independence. For adults, generally speaking, there's a greater focus on accommodating loss of independent skills and how to support the new normal. Next slide, please. As we have been discussing, the testing itself is just one piece. The assessment is an overall process of clinical management. Let's take a look at each of these steps in a little bit more depth. Next slide, please. First, we have data collection, which is a multiple step process that includes history gathered in the parent intake, observation of the child during testing, and direct test results and scores from the evaluation. Next slide, please. Our goal in history gathering is to determine what the child is bringing to the table. Things like, what have they been exposed to thus far? What are their potential biological risk factors or other general risk? For both of these questions, getting a good family history is important. We'll want to ask if there are family members with known diagnoses of ADHD, learning disabilities, language delays, mental health conditions like anxiety or depression. We also want to find out about recent family transitions, things like divorce, moves, illnesses, employment changes, and so on. Other things we'll be asking about are things like, has a child been able to take advantage of the learning exposure they've had so far? What has their development looked like to date? What have teachers been concerned about? Observations are another part of data collection and are a large part of our clinical work in the room with a child beyond the direct test administration. Within the testing environment, we are looking at how they interact in the structured setting. So, how well do they engage? What's their activity level? How social are they? And importantly, what is their behavior and problem-solving style under specific performance demands? So for example, do they get frustrated by complex tasks or become more engaged? Do they get overwhelmed easily or only with certain types of tasks? What's their persistence and endurance like? we're also able to do some observations of their behavior in more natural environments. What is their general appearance? How do they behave in the waiting room? What is their interaction like with their parents? And does this match what we heard in the interview process? Next slide, please. The next step in data collection, which is actually happening at the same time as a lot of our observational data, is the testing itself. A neuropsychological evaluation assesses a child's functioning across many domains. Things like overall IQ, attention and executive functioning, language ability, visual processing, fine motor functioning, motor, psychosocial functioning, and adaptive abilities. The specific concerns raised by the parents and the treatment team, as well as the known cognitive risk factors of the child's medical condition, will help guide how much testing is done in each area. For example, you would do more language assessment in a child with a history of language delay or a medical condition that caused aphasia. It is important to note that we do not typically assess much academic achievement for multiple reasons. First and foremost, issues with academic achievement can and should be assessed within the school setting. Because of this, it is typically not possible to get insurance coverage for academic specific testing within a neuropsychological evaluation. Additionally, as neuropsychologists, we are more concerned with the underlying cognitive weaknesses that cause academic achievement issues than the specific academic deficits that may be found. Sometimes academic testing is inappropriate. If the child you're assessing is intellectually disabled, you should not be diagnosing a specific learning disability. Within this context, we will sometimes include targeted assessment of specific academic issues when they are relevant to the child's medical disorder. So for example, there are high rates of dyslexia and neurofibromatosis type 1. It would be appropriate to look at reading in a child presenting with slow acquisition of reading skills and parental concerns for flipping letters in a kid with NF. Or you may need to do a basic reading screen in a child who presented with language deficits following a stroke or a TBI. Next slide, please. Moving on to test interpretation. When you're looking at a child's score tables, even if you aren't a neuropsychologist, you can fairly easily pick out what domain the test assesses and how well the child did compared to age expectations. So was it average, above, or below? But that alone can be misleading. Many tests can be impacted by multiple cognitive and/or behavioral factors. So a one-size-fits-all interpretation will often be incorrect for an individual patient. In general, tests rarely assess one domain cleanly. First, many tests require multiple sensory systems, so visual, motor, auditory. And second, deficits in one domain may impact performance on a test designed to assess another domain. For example, children with weaknesses in attention and executive functioning often have variable performance on learning and memory tasks. We would not then say they have a memory deficit. Why? Well, if you weren't listening when someone has told you something, how would you be expected to remember it later? You often find that they can easily recognize the information from a memory task if they're given prompts or cues about what was told, further reflecting that they actually have intact memory ability. Overall, this is why it's important to have a comprehensive battery that assesses these domains from multiple angles, so you're not just basing interpretation on a single subtest or observation of behavior. After you take these test-specific factors into account, there are patient-specific considerations that also impact a child's performance. Things like their age, their language history, their cultural background, and physical and sensory abilities. In summary, the tests are necessary for your case conceptualization, but not sufficient without all this other information. Next slide, please. Clinical analysis is the consolidation of all the data that you've collected in the context of your individual patient. It is where you synthesize the overall test data with relevant history and clinical presentation. It is here that you determine a child's strengths and weaknesses, both within their own profile and compared to their same age peers. You use this information to determine their pattern of performance as well as their overall developmental trajectory. Following clinical analysis, you can then make diagnoses if applicable. So did their test results, history, and observations of their behavior support diagnoses of things like ADHD, autism, a language disorder, generalized anxiety, and so on. Sometimes they may just show results that are consistent with a medical disorder, but they do not fit specific DSM criteria. Next slide, please. The final step in the evaluation process is management. First, we need to consider how this child's profile presents. In other words, how does it impact their daily functioning? Two children can have the same profile of scores, but present quite differently in how their strengths and weaknesses manifest and how pervasive their weaknesses are. Therefore, the management approach could be different. We also want to consider what are the risks for a given child based on their specific history and presentation. We want to think about all aspects of risk: cognitive, academic, social, emotional, and behavioral, as well as both short and long-term risks. Based on these factors, we can then develop recommendations to address and support these areas. The goal is to have a comfortable, socially and emotionally, and competent, adaptively, academically, and vocationally, child, adolescent, and eventual adult. Recommendations need to be tailored to the individual patient and their context. You want to consider the time required for given recommendations, the resources available to the family, and the family's goals and circumstances. Private therapies are not available to everyone, and resources are not just financial. It's also time, parental capacity, and considering the needs of the whole family. Something that you might value highly is not necessarily what a family's primary concern may be. The information gathered during the evaluation, the diagnoses that are being made, next slide, please. The information gathered during the evaluation, the diagnoses that are being made, and the recommendations being provided are then communicated through a variety of means. So feedback with parents, face-to-face or via telehealth, is a fairly crucial component that's used to communicate main findings and priority recommendations. These appointments also allow for questions and interactive discussion with the family. The report documents what, how, why, and what to do next, and is helpful for parents, schools, and medical team members. And then school meetings are interactive ways to help integrate findings and recommendations into special education plans. You can also use these meetings to provide additional information and psychoeducation regarding how the child's medical history contributes to their needs, both short and long term. And now I'll pass the presentation to Dr. Lundy. Next slide, please.
Hello. So as Dr. Pfeifle said at the beginning, I'm now going to discuss how we use a developmental orientation within our clinical practice. This includes the intersection between development and medical vulnerabilities, as well as the impact of medical conditions and treatment on the developing brain. Next slide, please. So kind of a quick note on terminology for our upcoming slides. When we think about what is a neurodevelopmental disorder in the context of pediatric neuropsychology, as you all know, the classification of neurodevelopmental disorders is used in the DSM to capture clinical presentations and difficulties that first arise in childhood, such as learning disabilities, ADHD, and autism spectrum disorder. By contrast, when we talk about neurodevelopmental disorders in the pediatric neuropsychology context, we are referencing disorders where there has never been a period of normal development due to the underlying medical condition that is present. Next slide, please. So, for example, things like extreme prematurity, congenital heart disease, and spina bifida are conditions where differences in development began in the neonatal or perinatal timeframe. There are a number of common neurodevelopmental and/or neuropathological conditions that are typically seen in pediatric neuropsychology, which we have listed here. I just mentioned the medical and/or neurodevelopmental disorders commonly seen. There are acquired or congenital brain injuries like strokes, brain tumors, TBIs, other disease insults such as epilepsy or comprised functioning of organ systems, iatrogenic insult, which is a big thing with the oncology BMT population as a result of chemotherapy, radiation, steroids, specific genetic syndromes, and structural brain abnormalities. All of these conditions occur in the context of dynamic change over the course of development. They all have the potential for derailing or changing development or setting up conditions for alternative developmental trajectories. Later acquired derailments, such as treatment effects, have the potential for promoting so-called late effects. So in summary, for all these conditions, the pathology is part of the developmental course. Next slide, please. So in terms of neurodevelopmental disorders, there's really a two-pronged impact on a child's development because they impact both the brain's overall capacity to learn and the child's ability to engage effectively with his or her environment. In other words, their availability for learning. An example of this would be a child with significant physical disabilities and limited mobility, which reduces their independent exploration of their environment, and that in turn reduces learning that arises from such exploration. So then, when we look at a child's neuropsychological profile, what we are looking at is the way the medical condition and their subsequent learning have interacted to create the current presentation that we are seeing. Next slide, please. And these neurodevelopmental disorders have an impact on cognitive and or adaptive domains. And although ideally we want to see independence in both, the impact can be disparate. Deficits in one do not always predict deficits in the other, and strengths in one do not predict strengths in the other necessarily. So for example, you could have a straight A student whose IQ scores are in the average range, but who struggles with daily tasks such as getting ready in the morning, learning new routines, and generally becoming more independent. Alternatively, you could have a child with significant cognitive impairments that limit their academic achievement overall, but who responds well to structure and routine, and he or she is then able to generally care for themselves. So, with altered developmental trajectories, the ability to function effectively may depend on the recruitment and activation of alternate neural pathways and circuitry that may be less efficient, demand more resources, or simply be inadequate to support other related capacities, ultimately resulting in areas of weakness. Next slide, please. So, from a theoretical framework for pediatric neuropsychology, there are important environmental and contextual considerations to take into account. Brains do not operate in isolation. One's brain does not function or develop in a vacuum. There are a lot of brain-world interactions, and thus context as well as the brain influences skill development and behavior. So environmental factors really matter. If a child has never been expected to or had the opportunity to engage in seated classroom desktop activities and they're struggling, would you then diagnose ADHD? No. If a child has never been exposed to letters, phonics, or books, would you diagnose dyslexia? No, you can't have dyslexia if no one has ever asked you to read or taught you what letters make what sounds. Context really matters. It elicits, shapes, and supports behavior and is multifactorial. In looking at the diagnostic approach and impressions that we use, it's more than just your data or scores. You have to take into account the contextual factors that contribute to what you are seeing with the child. Next slide, please. So Maureen Dennis, as well as Jane Holmes-Bernstein, Ida Sue Barron, these are really important leaders in the field of pediatric neuropsychology, and Dennis has a really nice developmental framework that helps visualize the main contributing factors influencing a child's presentation and neuropsychological profile. For pediatric neuropsychological assessment in the medical setting, the relationship between a child's underlying medical disorder and their current level of functioning and future outcomes is set by biological risk and moderated by age, development at onset, time since onset, and reserve. Next slide, please. So a little bit more in depth of this developmental framework, when you think about a biological risk, that includes all the medical risk factors associated with a given medical condition, be that genetic factors, structural abnormalities, neurotoxicity of treatment, etc. Age is a marker of physical and cognitive development. The impact of a child's medical condition will vary both with a child's chronological age and with the child's level of functional skill development. You need to appreciate the child's skill level at time of onset of medical issues and subsequent course of skill development. Time, since onset of medical conditions in children, affect both the level of cognitive function and their rate of acquisition. In other words, it is important to understand the shape of the curve relating the time since onset to outcome. A good example of this would be late effects, which are observed in children with cancer treatment. Cognitive impact may be minimal in the short term, but over time, as a child is not keeping pace with the rate of development, the gap between them and their peers widens. This can be observed globally, or as is the case for many medical conditions, specific brain functions and skills that come online later in development, such as executive functioning. Reserve refers here to factors that are available either to buffer dysfunction or to exacerbate it. So things like family history of learning disabilities, social emotional issues, socioeconomic factors, culture, etc., are really important to take into account. Next slide, please. I'm going to now pass it off to Dr. Cox, who will review medical disorders commonly seen in our specialty clinics and their associated neurocognitive profiles, and the frequently encountered neurodevelopmental and psychological diagnoses.
Great, thank you. So now I'm gonna, in the final section, I'm gonna review some examples of clinical presentations in the pediatric population. Next slide, please. So to start off, I'll go through the common referral sources here at UCSF. It's important to note that for our clinics, we only see children who have underlying medical conditions that impact the CNS. We receive referrals from a number of specialties covering a variety of medical populations, including neuro-oncology, cardiology, psychiatry, neurology, oncology, genetics, and we also perform pre and post BMT and SCT evaluations. Next slide, please. So the first medical population I'm going to review is congenital heart disease. To start, I'll give a quick overview of how CHD impacts brain development. Heart development begins early in gestation with a notable heartbeat at approximately 23 days. It is the first functional organ to develop and is tasked with supplying the oxygen demands and nutritional content via blood flow, to organs by the 4th week of gestation. In typical development, the heart is completely formed by 8 to 10 weeks. Early brain development occurs in parallel with heart development, and the 3rd trimester brings critical stages of increasing brain metabolism, growth, and cerebral organization, which are dependent upon adequate oxygen and nutrient delivery to from the fetal heart. So the brain of a fetus with complex CHD grows at a slower rate than expected during the 3rd trimester, which is typically characterized by rapid brain growth. And in fact, imaging research has demonstrated these infants have smaller brain volumes at birth. So with that quick primer of heart and brain development in utero, we know that children with complex CHD are at increased risk for neurodevelopmental problems and later cognitive and behavioral issues, even in the absence of early delays. Children who require surgery within the 1st year of life are at particularly high risk for later difficulties. And these cognitive and behavioral effects we see in this population are presumed to be directly related to those subtle changes in early brain development due to multiple medical factors, including that decreased blood flow and slowed brain development in utero that results in the brain being immature at birth and more susceptible to injury, particularly white matter injury. Additionally, these children have multiple invasive surgeries in infancy, which presents additional risks to neurodevelopment. Next slide, please. So concerns at the time of referral for children with CHD often include emotional and behavioral dysregulation, attention problems, learning difficulties and academic issues, and overall concerns regarding development, particularly with language. Next slide, please. The typical neuropsychological profile for children with CHD includes an IQ that's in the average range, though research has demonstrated that overall IQ for these children is statistically lower than controls. These children also have problems with attention and executive functioning, especially impulsivity, working memory, and flexibility. These weaknesses are often seen early, starting in preschool, and contribute to behavioral and emotional regulation difficulties. We're also seeing weaknesses in language. As with IQ, language scores are broadly average, though statistically lower than controls with variability. Early delays and milestones in apraxia are also seen. And we're also seeing a pattern of higher order language problems, such as pragmatics, fluency, phonological awareness, and sentence formulation. And overall, individuals with CHD have a higher prevalence of difficulties across the lifespan. It's important to note that children with CHD in the context of other medical conditions such as genetic disorders and prematurity tend to have more challenges, particularly with overall cognitive functioning and IQ. Next slide, please. In regard to comorbid diagnoses and common recommendations for children with CHD, the most common is ADHD. Prevalence rates vary by type of CHD, but clinical research indicates that is up to 50% in children with single ventricle CHD. There are higher rates of autism spectrum disorder, but we're often seeing social and behavioral difficulties that do not meet full diagnostic criteria for ASD in these children, but they would benefit from the same interventions and services that children with ASD would. There are also higher rates of anxiety and language disorders. And for children that we see through the Healthy Hearts and Mind program, I am often recommending supports for attention and executive functioning, academic interventions and supports, behavioral therapy or PCIT, and social emotional supports across settings. Next slide, please. The next population I want to highlight is spina bifida. Spina bifida arises from a failure of the neural tube to close. This happens extremely early as the neural tube begins to develop on day 18 of gestation, often before one knows they're pregnant. The most severe and most common NTD referred for an evaluation is myelomeningocele. This is an open lesion in the spinal cord through which neural elements of the spinal cord herniate. Common neurological findings for this population include Chiari-2 malformation and hydrocephalus. Sorry, it just told me I was spotlighted, so it covered my stage, sorry. And hydrocephalus, and this is typically caused by obstruction of the CSF due to the Chiari-2 malformation. This typically requires shunting, though occasionally children do not progress to requiring a shunt. Shunts themselves also present increased risk factors. They can be prone to malfunction and require neurosurgery to fix. We also see partial dysgenesis of the corpus callosum in children with spina bifida, which represents congenital disruption. Next slide, please. Due to their physical disabilities, almost all children with spina bifida have early motor delays and receive therapy services starting soon after birth. Presenting concerns also include attention problems and behavioral dysregulation, as well as general learning delays and a slower pace of learning overall. Many times these children also experience social difficulties, including bullying. We also see language issues in this population, though this is less common. Next slide, please. Regarding the neuropsychological profile for spina bifida, those with hydrocephalus have lower IQs than those without, and those without hydrocephalus have similar intelligence to typically developing peers. Generally, they have stronger verbal than visual abilities. We also see fine motor deficits such as slowed speed, poor dexterity and graphomotor construction, and weak hand-eye coordination. We also see some language weaknesses. For children with hydrocephalus, they present with what we call cocktail party talk, meaning they have a pattern of reduced meaningful language content despite fluent speech production. We also see difficulties with oral motor skills and pragmatics. For attention and executive functioning, children with spina bifida have particular difficulties orienting to their environment and tasks. They also struggle with what we call cold cognitive functions, which is initiation, working memory, planning, and organization. For academics, most difficulties are observed in math, though we also see reading comprehension problems, particularly inferences, as well as writing issues, which is often due to a combination of fine motor difficulties and executive functioning impacts. Adaptive or daily living skills is also impacted by both their physical disability as well as some of those cognitive effects, particularly executive functioning. Next slide, please. Medical factors that impact the cognitive profile primarily relate to the level of the spinal defect. Higher lesions are associated with more brain abnormalities and thus worse neurocognitive performance. Data from clinical research indicates that those with upper level lesions tend to have lower IQs, lower academic scores, particularly in reading and math, and lower adaptive skills scores. There are also interaction effects for children with Hispanic ethnicity. Children of Hispanic ethnicity with higher level lesions have higher rates of intellectual disability above and beyond the effects of the lesion alone. In general, for spina bifida, visual scores are lower than verbal scores, but for children of Hispanic ethnicity with low SES, the opposite pattern is seen. And this is not the case for children of Hispanic ethnicity with higher SES or those of non-Hispanic ethnicities with lower SES. Next slide, please. Regarding comorbid diagnoses and recommendations, we see high rates of ADHD in this population, about 30%. And we also see a lot of learning disabilities. About 3% display isolated reading disabilities, 29% isolated math, and 26% with both reading and math disabilities. Intellectual disability is present in about 20% of these children, and anxiety and depression symptoms are also present and often related to social difficulties and/or bladder and bowel continence. Recommendations include supports for attention and executive functioning, evidence-based learning interventions, transition supports, and individual and/or family therapies. PT and OT are also recommended, but these are usually already in place. Next slide, please. All right, the final example I'm going to give today is acute lymphoblastic leukemia, or ALL. Despite the elimination of cranial radiation from most treatment protocols for ALL, intrathecal and systemic chemotherapy have been shown to cause acute and long-term damage to the brain. Common morphological changes found on neuroimaging include white matter changes, widening of the ventricles or sulci, and cerebral calcifications. Reduced prefrontal cortex, cerebellum, and cortical white matter volumes have also been reported. Next slide, please. Presenting problems include increased academic difficulties, attention problems, slower work speed, fine motor difficulties, difficulty with daily living skills, and psychological and behavioral issues related to treatment are also seen, including symptoms of anxiety and depression. Factors that can influence this are not just fear, worry, and adjustment related to their diagnosis and treatment, but also social isolation, physically looking different, and potentially no longer being able to engage and interact with their peers as they did before. Next slide, please. And research has consistently demonstrated that leukemia survivors treated at a young age are likely to display some degree of neurocognitive impairment secondary to disease and treatment-related factors, specifically in the areas of processing speed, attention, and executive functioning, especially working memory. Additional areas of vulnerability may include visual spatial processing and visual motor functioning. Memory difficulties are also reported in children with a history of ALL, but this is typically related to executive functioning weaknesses. And over time, these core deficits may lead to gradual declines in global intellectual function and academic achievement that are referred to as late effects in treatment, which Dr. Lundy referenced earlier. As displayed in the graph here, these are not declines in functioning, but rather a slower rate of development that leads to a widening gap between these children and their peers over time, which therefore can result in a drop in IQ or academic functioning, as these are norm reference standardized scores. Next slide, please. Children with a history of ALL frequently exhibit difficulties consistent with ADHD, with more often an inattentive presentation. Anxiety and depression are also often seen in children post-treatment. And for this population, there is often a question of learning disabilities, particularly reading. This is an example of why it's important to consider timing and age of diagnosis and treatment. If this corresponds with kindergarten and/or first grade, when students are being taught reading fundamentals, we're more likely to defer on a diagnosis of a specific reading disability, but still recommend reading supports and interventions to address these weaknesses. Other common recommendations include accommodations and supports for ADHD and slow processing speed, fine motor supports, as well as individual therapy. Next slide, please. That's all we have today. So thank you so much for joining us. And I believe we now have some time for questions. Thank you.
Wonderful. Thank you very much. So I'm going to open it up to folks. If you'd like to unmute yourself to ask questions, or feel free to put it in the chat.
I've got a question. Thank you very much. This was super, super interesting and helpful. I do kind of psychodiagnostic evaluations in the health clinic. And I love hearing about how the neuropsych is kind of similar. It's similar in some ways and different. So one question I have is about the reports that you're writing, because this is something we talk a lot in health about, kind of what is the level of detail that goes into your reports, and like who's the consumer of the report? Is it the parent? Is it other medical professionals? Are you focusing on primarily on kind of your summary and treatment recommendations, or do you put a lot of detail in terms of kind of history and data from your testing?
I'll start. Yeah. Go on. I mean, I think it's similar to you all. It's something that I think we're sort of like constantly working on,
Yeah.
you know, how to tweak and address and make sure we're getting everyone what they need while also like, you know,
not writing a 50-page report, right?
all that. I think we've put a lot of effort in recently to doing, you know, less in the test results section and really trying to focus on just like the take-home message. It's a lot of what we focus on with our students is learning how to write reports that aren't just like, this was average, this was low average, and more about just like, what do we need to say about their language overall? And then focusing in the summary, obviously, on like, how do we, you know, kind of what we talked about here, like, how do we put all of this information together? How does it relate to the medical? What does that mean moving forward for this child? Like, what are they going to be at risk for? And focusing on that. And then we do have a lot of consumers of the report, which makes it hard to write for any one setting. You know, if it was only the medical team, we would write even shorter reports, I think. But, you know, they are often used by families, you know, for school supports, et cetera, which, you know, they tend to want to know more and more and more. So, you know, that's kind of the balance we're trying to strike.
No, I think we're struggling with all the same things. So,
What we've tried to really do from a background perspective, instead of really getting lost, and because some of these kids have extremely complex medical histories. And so for each disease disorder, we try really hard to kind of highlight the areas that are going to be most important to understanding what their neurocognitive and or psychosocial profile is going to look like. And so, you know, for oncology, it's going to be how much radiation, chemotherapy did they receive? Did they end up having a bone marrow transplant? How did that go? Did they have complications? Certainly, as Dr. Cox to with her patient population, how many surgeries did they have within the first year of life? For spina bifida or, you know, neuro-oncology patients, what they have, what were their complications? How many shunt revisions were their complications from their first surgery? How many surgeries have they had? How old were they? I mean, all those things, we try pretty hard to kind of almost even bullet that and background it so that it's distinct, but also the medical team doesn't care as much about that, but sometimes the educational team cares a lot about that. Or sometimes for families, it's so hard to know, how do I tell everybody everything that we've been through? And so we work really hard with families, like, what are the big things that you care in terms of globally this child has been through that you want other people to know? And the other stuff, it doesn't matter quite as much.
Okay.
Yeah, and just one quick thing I'll just add to that is I think for many of the populations, we see one of the like main consumers is a school, right? That's like when parents kind of ask, like, where can this help me? This can be helped to school. There's huge portions of our reports that are recommendations. But a lot of times that report's the first time that school is really going to understand how this child's medical condition relates to their presentation. So specifically to like with kids I see with CHD, a lot of times people are not making that connection between their
biological,
their heart and their brain, and how does that relate? And so that is part of this education, and parents often have been fighting against that for so long. The idea that their heart is fixed, so they're fine now, and so this is a big component of what we do. So just that's the final aspect, just to emphasize there, that I think no matter who the consumer is, I think I hear from really multiple the schools, the parents, that's just one of the most
impactful things. Okay. Great. Thank you, everybody.
I think in general, summary and impressions and then meaningful recommendations is really all the report needs to have.
Someone, Pablo, contributed in the chat a good article on how to approach report writing. They surveyed many of the stakeholders of NP evals, and I opened it up, and I'm just going to read the last sentence of the abstract. The survey highlights differences between writing practices of neuropsychologists and what referral sources identify as the most valuable aspects of reports to assist them in caring for their patients. So to all your points, who's the consumer of this information, what are they going to do about it, right? You almost have to write like different reports for different people if we had all the time in the world, right? Yeah. Gloria, go ahead and ask your question. Feel free to unmute yourself. Dr. Castro?
Yes.
Are you still there? Okay.
Yes, I'm here. I would like to ask you if you do this type of neuropsych developmental assessments with infants and toddlers.
Well, I think, Gloria, there's not really great instruments for, that you have to have kids at an age. You can't assess memory in a 2-year-old. And they need to have language for a lot of these tests. So certainly, I would say from an infant perspective, not really any of us, but certainly I would say from probably 18 months on, Dr. Cox, certainly in her congenital heart disease population, she's seeing those kiddos early because we want them to be getting the interventions that they need. And I think for all of our patients, we do some sort of developmental assessment if they've received treatment or have a medical condition so that we can set them up to make sure they're receiving the early intervention services that we know are so important and so critical, and making sure they get, channeled, be it, in the state of California, it's regional center, be it in, preschool program that's going to really support them. So we do, though I just think we're limited in the type of instruments that are available, the types of assessments you can do. Obviously, as a child develops language and things like that, there's just more that they can do, and then age matters. You can't test certain things when they're really little. And the instruments themselves, are good at oftentimes measuring where a child is at in the moment, but they're not necessarily predictive of what that's going to mean later on. And so I think that's always an important thing to make sure the medical team and parents understand.
Yeah. Yeah, and I'll just quickly piggyback on that, is that so for certain populations, there's also crossover with our high-risk infant follow-up clinic. I think some of those folks are on the call too. So for example, for kids with congenital heart disease, many of them are followed through 2.5 through the high-risk infant follow-up clinic, also children with a history of extreme prematurity. And so those are, so then I'm usually, so for my clinic, then I'm following them later, but it's not all children meet criteria for RIF. And so then I'll see those kids earlier, like Dr. Lundy mentioned, as early as 18 months. The other factor that comes up for multiple medical conditions that specifically I see is that if they have a history of a underlying medical condition, there's a question of autism. I also will tend to see them younger to answer that question as well.
Thank you.
I think too, Gloria, another thing just to think about for a lot of these medical populations, there's actually national standardized batteries, generally speaking, that we certainly follow in our clinical practice. And so there are actual time points that are designated for like the oncology population, for the CHD population, for spina bifida. So those are also other guidelines that we use that are important, I think, just in terms of how you developmentally assess these kids, given all the developmental factors we discussed, that we know that they're going to potentially struggle with going forward. So those timelines are important too.
Thank you.
There's another question in the chat. Forgive me if I'm mispronouncing your name, Maria Elise Goen. Did I get that right?
Yes. So I know you guys have been following the congenital heart patients, but we have a new program, the pediatric heart failure heart transplant patients, which has only been at Mission Bay for about 3 years. And we have a lot of heart transplant patients that could probably utilize this, type of evaluation. We're just wondering who would we contact if we have a patient that meets this need.
Yeah, so you can go through our typical referral channels to Healthy Hearts and Minds. I actually, Megan Keating.
I work with Megan. She's off today,
she's referred. Okay, she's referred. So I've seen several of your patients actually.
Okay.
So it's a new thing that we're starting to see them. But if you want to talk to like the specific referral stream, Megan's very familiar because she's referred several of our patients, and including some that actually have that umbrella coverage, even though they're Kaiser.
I think we talked about that. Okay. Yeah. All right. Great. Thank you.
All I have a quick question. How often, depending on the primary presentation, how often do you recommend that evaluations be conducted?
I'd say our typical tests, like reevaluation, is not sooner than 3 years. But there can be differences in that. So sometimes when you see a younger child and you're kind of monitoring a couple things like pretty closely, then we might recommend an earlier reevaluation timeframe. And then with other kids, if we have a really good initial evaluation, like for the spina bifida kids I see, sometimes I can get a lot of really good stuff set up for them early in elementary school. And then maybe I don't need to see them for more like 5 years until they're making that transition to middle school. So it can be patient dependent, but the typical reeval is around 3 years.
I would say too, it depends on the medical condition itself. So I mean, Stephany can speak, Dr. Cox can speak a little bit to that, regarding some of the kiddos she sees. And I think for the oncology patient population, particularly the brain tumor patient population, if they're treated under the age of 5 with both radiation and chemotherapy, what you're going to be getting across that developmental time can really vary. And so in terms of them plateauing off from a skill development perspective, so seeing them under 8, probably every 1 to 2 years, especially if they're struggling, is actually typically what we may do. It just really depends on the medical condition, as Dr. Pfeifle alluded to, and kind of what we are concerned about kind of in terms of supports and needs. As we talked about these late effects, they seem to be okay at 3 or 4, and schools unfortunately sometimes tend to be fairly reactive to problems and not very proactive about problems. And so even they're in kindergarten, first grade, they are not reading it. They're not reading it, and you've warned them about this and they're not reading. You really kind of need to help, I think, intervene with certain medical patient populations that we know what the known risks are if nothing is really happening and school is not really engaging on the level that they need to be.
Yeah, one thing, based on that, I worry about caregivers feeling of empowerment around that, like, or knowledge about when to ask for a reevaluation or when there's a need. Like, there's that communication between the caregiver and the treatment team. And if a reevaluation would be helpful in 3 years, who's going to communicate that it's in 3 years? And remember, in 3 years you gotta work with the school, like who's advocating for that?
We do we are pretty on that. So I think in the feedback, we talk about that with parents a lot. That's all part of it, and school teams and the medical teams. So I think the one advantage of working and being embedded within the medical teams, Dr. Pfeifle is in the spina bifida multidisciplinary clinic twice a month. I'm in the neuro-oncology clinic once a month, the neurofibromatosis clinic once a month. And our specialty providers communicate with us. If we have a patient who's had a ruptured AVM or a stroke, they'll say, hey, this patient's going to be about 9 months out at this time. So can we see them for that first evaluation? And then we'll put on the next time to see. So we try, obviously that doesn't always work and families can be lost to follow up, but in general, we even have families that are like, okay, I think it's almost time. Can you please put me on the list? So I think that, there's different ways to do that. We're not so huge yet that we're able to kind of monitor that with the relationships we have with the medical teams themselves and also with our families.
Yeah, so I think most of us do this. At the end of the report, it actually says when they're due for their reevaluation, and then depending on the clinic and coordination, the goal then is, especially with Healthy Hearts and Minds program, is that actually there is an entire tracking program. So then the family is contacted for when they're due for their next evaluation. And then just the last thing, as far as like timing goes, some of it really in the context of the medical condition, what the national standards are, but then also what I'm encountering a lot, especially for these younger kiddos, is if they've had no intervention before I've seen them, and maybe I'm seeing them at 4 or 5 for the first time, and they're presenting with lots of deficits. I don't want to wait 3 years before I see them next to really give parents an idea about trajectory, and also their recommendations could change dramatically now that they get that behavioral therapy, that speech therapy. They're now enrolled in preschool. So just wanted to add that in as well.
There's another question in the chat. Cher Rose, did I get that right?
Yes.
Oh, go right ahead.
So I work out in a private practice, and I do teletherapy now with a company. And I get referred families, and I've been doing this for a long time, and the kids have either never been appropriately diagnosed or misdiagnosed. And it seems that it would be beneficial to have a neuropsych. The problem is especially parents in the donut hole, they have to pay for it out of pocket typically. So I'm just wondering, do you know about how to get insurance to cover it? Any suggestions? And also, the school will usually reimburse in the end, but and where are there sources to go to for maybe low cost testing? I don't know, I'm just trying to figure out how to help these families.
I mean, access to neuropsychological evaluations in the community is a major problem, and quite limited for the reasons that you've noted. It also comes down to like what insurance will cover. So a lot of the, here we only can see and bill on the neuropsych codes that, require medical diagnoses for families where it's more of a, kind of neurodevelopmental concern like ADHD or a learning disability. You basically have to find a provider that, is set up to take insurance, which not a lot of the private practices are. So yeah, I mean, it is a problem. I know like there is one clinic down in the South Bay, the Gronowski Center, that does some sliding scale stuff down in the South Bay. But I'm not aware of other clinics that might be offering that kind of service.
Do schools offer ever, do schools that are training neuropsychs do, I don't know, pro bono work, or because it's a student, it's
school, if there's a specific issue for a child keeping up in school and they attend a public school, then you can have the parents put in writing a request for special education eligibility evaluation. And if they put it in writing, then it starts the clock on the school to respond. And they're, kind of required to make sure that they find individuals at their school that have learning needs that aren't being addressed. And then you can get some psychoeducational testing that way.
I'm a counselor actually, and
yeah.
usually schools are very resistant against neuropsych, that they'll do anything just about to avoid it.
Yep.
Okay, thank you.
Mm-hmm.
We have a recommendation in the chat. West Coast Children's Clinic in the East Bay takes Alameda Medi-Cal. Kristen Flores, did you want to add anything?
No, I work in primary care along with Dr. Takayama, so we do see a lot of these patients. But I understand that they take it, and there's also a agency in San Francisco, and I'm blanking on the name, and I think it's on Franklin Street. It might be the Access Institute, which has provided neuropsych evals for Medi-Cal patients in the past, or also provides sliding scale, as far as I understand.
Great. Any other last comments? We have less than a minute left, but I like to use up every single second we have. Okay. Well, please join me in saying a huge thank you to the three of you. This was an excellent talk. I certainly learned a lot. It is not my area whatsoever, and I took some notes. So thank you very, very much. I appreciate your time. Take care, everyone.